Hey guys, Jimmy here. So in this video, I want to do the giveaway again. So I'll be doing that drawing here because unfortunately Legendary JR never did get back to me regarding his win. I also, in this video, I am going to share some things I think about this coronavirus, and this is by no means am I a doctor or a medical professional like for the CDC or anything like that. But I've had exposure to the effects of this, and I've seen, I've been in the field that I'm in for 4 years, so my experience is still much more to gain as far as knowledge and everything. But I've seen the flu, I've seen pneumonia, I've seen people get acute respiratory distress syndrome due to those viruses or bacteria, but I haven't seen anything quite like COVID-19. We don't have any way of really treating it that's actually founded in or has any foundation in any science or anything. There's no real treatment. Like flu A, they would treat with like Tamiflu, and that's been shown to be effective. And of course, we have flu vaccines, but this is different. Another thing is anybody who is put on a ventilator for the flu, usually they don't have a lot of systemic effects. We don't have to necessarily give them, Levophed, which is a medication that's meant to cause vasoconstriction. It helps to elevate blood pressure. A lot of times we have to chemically paralyze these patients that are put on ventilators for COVID-19 because they are so asynchronous with the ventilator that the ventilator isn't necessarily doing its job, because what the ventilator does, and I'll try to depict this in a video in the future, but what the ventilator does is, for these patients, they're often requiring high pressures of air. So basically what you can do on a ventilator is you can set a volume or you can set a pressure. There's many other modes in the ventilator that you can do where it allows people to spontaneously breathe on the ventilator. There's modes where you can kind of lock people out and have the ventilator solely do the breathing for them. Then, of course, you can sedate them, paralyze them, and all that, and try to control their ventilation. But basically, with the, I'm going to show you a couple of things on my computer here. What's happening is, I'm going to try to show this. Let me get it to focus. So what's happening is these people are going into ARDS, which this is a good chest x-ray that depicts it. You see there's bilateral infiltrates. So normally the lungs are supposed to be somewhat similar looking to that picture right there. There's not supposed to be that density. They're supposed to be air-filled. Air is usually transparent. That's why if you were to see like anything gastric, you'll see, the air in the intestines and so on. But what's happening is their lungs are being put under stress, the inflammation. What happens is fluid kind of comes in, inflammatory mediators, things like that. It agitates the lungs. You're left with what you can see as these what are called air bronchograms. So you can kind of see right here you have a conducting airway. So that's a conducting airway. You have a couple conducting airways right here as well. Those conducting airways are not beneficial to oxygenation. What they do is allow the air to then get to the alveoli, which is where gas exchange occurs in the lungs. But these alveoli are so compromised by fluid and all of this inflammation that it doesn't allow for the diffusion of oxygen into the blood. So what's required is these people have to be put on high pressure ventilation, which with a ventilator and an endotracheal tube or a tracheostomy with being trached, basically we have a cuff that you can seal, which is, the airway would terminate about right here below the clavicles. So below the clavicles, before the bifurcation of the left and right lung, there would be an artificial airway placed. And it's, in fact, I can see it right here. So this is the artificial airway. If you can see that opaque line right there, that is the artificial airway. This looks to be the carina right here. So that's the bifurcation between the left and right lung. So there is a cuff that's on this endotracheal tube that seals the airway so that pressurized oxygen and air can be delivered to the lungs in order to open and recruit these alveoli that then deliver that oxygen to the blood and allow that to diffuse into the blood. So whereas this person, if they were not on a ventilator, what they're going to do, they're going to have a very, very hard time drawing in air and effectively breathing. So they require this mechanical ventilation that can be given by pressure or volume. So if you target a volume to deliver to somebody's lungs based on their height and their sex and everything like that, then that volume may be appropriate for them under a typical circumstance. But because these lungs are so affected, what it happens is that the pressure is dependent on the lung characteristics. So when you deliver a volume to these lungs, it will achieve a pressure that is much higher than if you were to deliver that same volume to healthy lungs. So these people have to be paralyzed in order to, sometimes they have to be chemically paralyzed in order to effectively ventilate them, because if they're asynchronous with the ventilator, the pressure is, you can't count on having enough pressure within the airway to effectively ventilate them. So what happens is sometimes these people have to be put on what's called APRV, airway pressure release ventilation. So when they're placed on that, what it is it's a sustained pressure. So there's a sustained pressure of about 4 seconds. So imagine air being delivered to you for 4 seconds, and that pressure is sustained. So it's constantly reaching a pressure, delivering air to achieve and retain that pressure in the lungs. Then what it does is it drops the pressure. So it drops the pressure, and there is where ventilation occurs. There is where the ridding of CO2 occurs. Oxygenation is taking place in that pressure sustained, that sustained high pressure. Then that pressure drops. That's where you ventilate and rid the body of CO2, which is a byproduct of metabolism. But it's necessary to rid yourself of that. That's why people breathe with a paper bag when they're anxious or whatever, because they're hyperventilating. They're ridding themselves of too much carbon dioxide. So they want to rebreathe their own carbon dioxide that they're getting rid of in those quick, panicked breaths. So what's happening with COVID-19 is these people are having, in severe cases, they're having ARDS, bilateral densities in each lung. That what will happen is if somebody has like a pneumonia or something, it may only affect one lobe. On the left side, left lung, there's 2 lobes. Right side, there's 3 lobes. The left side, you have room for the heart. Right side, you have 3 lobes: a right upper lobe, right middle lobe, and right lower lobe. But what's happening is you normally, when people have a pneumonia or something like that, or even, they have congestive heart failure or whatever, you can put them either on one side or the other. Sometimes you might have more density in one lung than another, and you can put them on the less affected lung so that gravity sends more blood flow to that less affected side. But with this, there's not a lot that you can do. Sometimes we prone people and put them on their chest, and then we rotate them periodically, but there is not a lot you can do when it gets to this point. And sometimes it has been getting to this point with patients with COVID-19. And what's scary about this is that this can systemically, this is doing much more to people than anything I've seen. So when you have these high pressures being delivered by a ventilator to the lungs in order to oxygenate a person effectively, because of course your organs depend on oxygenation, you can have damage to vital organs if either blood pressure isn't maintained or if, of course, oxygenation isn't maintained. If you don't have effective perfusion to those vital organs, then those organs can be severely damaged or die. So what happens is when you put people on a high pressure ventilation like APRV, like I said, it has a high sustained pressure, drops that pressure to almost zero, and then goes right back up to that high sustained pressure. So your ventilation occurs in that drop, your oxygenation occurs in that sustained pressure. But what's happening is these people are requiring both the oxygenation and ventilation aspect of APRV, of course. So it can have cardiac effects because the filling of your heart depends on obviously having space to fill. You don't want there to be resistance to blood flow out of the heart. So you have the pulmonary vasculature that depends on blood flow, of course. You don't want there to be resistance to pulmonary vasculature, blood flow. You don't want systemic, in the systemic circulation, you don't want resistance to blood flow there. That's why, of course, high blood pressure, blah, 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 all that is bad. But you don't want any resistance to blood flow. But what this does by having to ventilate people with high pressures in the lungs, it's going to increase resistance to blood flow. It's going to limit the ability of the heart's capacity to fill, and it's also going to affect its ability to basically expel that blood per contraction. So you have issues there. You can have backing up of the blood flow. Like you can kind of tell this is kind of cardiomegaly, which is an enlargement of the heart. And you can also tell there's a shift to the middle of the chest cavity. So what's happening is you can't have effective systemic circulation because you've affected the heart's capacity for filling and for ejecting blood from the heart. So that causes issues in itself because then you can have damage to the kidneys, you can have damage elsewhere, of course. But what's required is these blood pressure medications that sustains blood pressure effectively so that you have adequate perfusion to the brain, to the kidneys, to all sorts of things. And when that's compromised, you have issues. So this is a serious thing. These air bronchograms indicate that you can see air in those conducting airways. But like I said, those conducting airways, I apologize there, don't do anything to help gas exchange. They, of course, are necessary for getting the air to the, where gas exchange occurs, but otherwise they're not going to do it. So this is another air bronchogram. You have atelectasis, which of course is going to happen with the opacities and densities in the lung because you can have absorption atelectasis where when you have to put these people on high oxygen, you flushed out all our other gases. So once oxygen's absorbed into the body, it leaves no gas in the lungs. So you can have absorption atelectasis. This is, pulmonary edema from heart failure. Lung consolidation is what's occurring in ARDS. So ARDS, acute respiratory distress syndrome, can occur in those who are critically ill or have significant injuries, is often fatal, the risk increasing with age and severity of illness. This is an article all about the effects on positive pressure ventilation on right heart, left heart. And then we have spontaneous breathing. Spontaneous inspiration was associated with a simultaneous fall in arterial pressure, pulmonary artery pressure, and left atrial pressure. The pleural pressure fell more than did chamber pressures, which resulted in increased transmural LAP, PAP, RAP, right atrial pressure, and aortic transmural pressure increased. So spontaneous breathing, you're going to have necessary drops in pressure so that it allows for flow. So just like the drop in pressure in the lungs and in the chest cavity allows for the drawing in of air, it's similar with blood flow. So you need that ebb and flow in order to really have anything. So what it's saying is basically the right ventricular afterload, such as pulmonary vascular resistance and right ventricular output impedance, are augmented during the mechanical ventilation inspiratory cycle as well as spontaneous inspiration. The vascular resistance of alveolar vessels increases as alveoli expands with gas, and vessel compression occurs as alveoli inflate. Thus, tidal volume is the primary determinant of right ventricular afterload. So if you have an increased afterload, that means that's not good. That's not what you want. You don't want an increased afterload. Augmentation in right ventricular afterload necessitates the right ventricle generate greater pressure to eject blood into the pulmonary artery. So that is depending then on your heart health to some extent. You need that heart, you need strong contraction in order to ensure that right ventricle is able to deliver blood to your pulmonary vasculature. So your right ventricle is delivering blood to your pulmonary vasculature, your left ventricle is delivering it to your systemic vasculature. So there's effects on the heart, but we just gotta get through this. And I just really want to tell you guys about wearing your masks, protecting others. Just do your best to support your communities any way you can by protecting yourself. And by protecting yourself, you're protecting others. Because if you want to look into information about viral load, basically your initial dose to the virus can impact the severity of disease, also then impact the amount of virus then you can pass along to another person. If they're compromised in any way, that virus, of course, can replicate quicker and in a more aggressive fashion in that susceptible host. So limiting your exposure is key. I can tell you that from what I've seen, we've seen a lot of professionals that worked in an environment or were in an environment where they were exposed a little more often than maybe somebody just walking down the street. That includes like correction facility officers. We had EMT, we had hospice nurse. So we've had some people that, otherwise if they hadn't come in contact with this, probably be around today. And it's sad to see, despite some people having underlying health issues, this is not something this is rather aggressive, and a lot of things they probably would have made it through, but this is something that is just, we don't have necessarily an effective way to treat it. It's almost like we do what we can, but ultimately it's up to the body to do what it can to ultimately fight it off. So, any questions about what I do or about this video, please don't feel leery to contact me, I guess. And please, just disregard the political ranting that goes on both sides. I want to see news that talks about advancements, talks about treatment, talks about where we can look to be here in a few months, hopefully with flu season coming around. Hopefully we don't find ourselves in an awful situation. But so here is the winner. We're going to do the 30 TCGO code winner. So we've already filtered duplicate users. I've already gotten the unique commenters. We have 25 unique commenters. So let's go ahead and get started here. And I appreciate you guys listening. It's just it's been very hard to see the commentary on this entire thing from outsiders, and it's tough. So I appreciate anybody listening. We have Evan Zoo, actually, and I know you love the codes, so I'm sure you'll be happy to get them. So once again, thanks everybody for entering. Evan Zoo, congratulations on winning the second drawing for the 30 TCGO cards. And I do apologize once again to Legendary JR. Please do continue to enter, and hopefully get back to me next time that we draw a winner. All right. Once again, thanks Evan Zoo for entering, and I'll be in contact with you. And thank you guys for hearing me out. All right. Have a great day and stay safe.